going to share some of that with us today. Has done a lot in communities, prevention and treatment of substance abuse in New Mexico, and she brings that to Oklahoma. We're very happy and pleased to have Dr. Fink with us. So Dr. Fink, I will turn it over to you.
Okay, thank you very much. I'm very happy to be here. Let's see if my slides will advance. So I have no financial relationships or affiliations with any commercial interests or ineligible companies to disclose today. What I hope everyone will walk away with after this presentation is being able to integrate information about the common principles that underlie family-based approaches to substance use disorder treatment, be able to integrate information about how family members can influence treatment engagement and substance use, and then to utilize information to obtain training in the delivery of these family-based treatments. So the overview today, I've kind of grouped these according to treatments that facilitate treatment engagement. So this would be the community reinforcement and family training approach. Then couples and significant other approaches. So when we are doing substance use treatment, like with families, quote unquote, we include anybody in that significant other category that has a meaningful relationship with our patient. And so I have 3 treatments to talk about under that. And then I'll talk about brief strategic family therapy that is a treatment approach for children and adolescents. But I want to talk about the use of significant others in substance use treatment. It's a pretty powerful and potent way to improve outcomes for patients. In a recent meta-analysis that was done of 77 studies that compared treatments that included a concerned significant other versus individually based treatment, which we typically think of, they found that there was a significant effect of the concerned significant other involved treatment beyond the individually based treatments. So individuals who went through substance use treatment like relapse prevention or treatments like that did well. They had good abstinence rates. They had lower days of heavy drinking, lower days of substance use. But those that did a treatment that focused on the family and included a family or other concerned significant person in the treatment did even better. And so overall, this yielded about 3 fewer weeks per year of substance use for those individuals. So that's a pretty significant effect. And this effect endured across the different types of concerned significant other involved treatment, and endured for a year to a year and a half after the end of treatment, which is just an outstanding outcome. And so when we look at concerned significant others, we see that these folks do want to be involved in the treatment of their loved one in productive ways. And I would like to also mention here that when we are talking about concerned significant others involved in treatment, it's not the Al-Anon treatment approach that is, encourages family members to detach with love and things like that. We are engaging the family members actively in ways to make productive changes in their loved ones' substance use. And family members want that. They don't want to detach with love and disengage themselves from their loved one. They really want to help. And we also see that in these concerned significant others that they benefit from it as well. They have improvements in their physical and psychological well-being from being involved in the treatment with their loved one. So both parties benefit from these types of treatment approaches. So if these are so great, why don't we use them just universally? Well, there's been some major barriers identified to the uptake of these treatments in broad treatment settings. For one, there's really been few dissemination studies conducted. There have been a lot of randomized controlled trials conducted, but then they've not done the next step, which is to disseminate it, treat clinicians in treatment settings, and then track outcomes from there. Also, these types of protocols tend to be kind of lengthy and complex for clinicians to learn and deliver. And you'll see that as I discuss some of these treatments later on. And then clinicians also believe that findings from controlled trials have limited applicability to their ongoing clinical work. So they don't quite know how to implement that in their day-to-day use. And they feel they're a little too complex for their day-to-day routine use. Or they feel, well, my patients don't quite fit, don't look like the patients who were included in those clinical trials. So I'm not really sure if they work. And from the family or the CSO perspective, those folks also worry that they may be blamed for the patient's substance use problems or be held responsible for how well that patient does in treatment. And so it makes them a little wary of participating in that treatment as well. So you'll see that one of the treatments that I talk about a little bit later, we really worked to address these barriers and limitations to improve the uptake of these types of treatments, because the outcomes are just so superior to individually based treatments for substance use. But I'm going to switch gears a little bit here and talk about our first family involved treatment that is really focused on engaging the loved one in substance use treatment. And this is the community reinforcement and family training, or the CRAFT approach. This was developed by Bob Myers and Brenda Wolf, and Jane Smith they've continued to disseminate this. Bob Myers, if you ever have an opportunity to do a training with him, I have the link to his webpage at the end. He's a fantastic trainer. He's super dynamic, and you'll really walk away feeling like you have some mastery over this material. And so this is a behavioral approach to concerned significant other, or CSOs, to engage a treatment refusing substance user into treatment. And what they've found is that CSOs have the most substantive information about the family member's substance use patterns. They know the ebbs and flows and what are antecedent events to increase substance use and things like that. And so because of this intimate knowledge, they can also play a significant role in helping family members get into treatment. And folks with a substance use disorder report that family pressure or influence is often the main reason that they seek treatment initially. And so this really teaches folks how to do it in a positive and constructive and efficacious way. And so it can be delivered individually or in groups. A good colleague of mine, that's what she did her dissertation on, is seeing if CRAFT can be delivered in a group format, and she got great outcomes with that. And the family members really enjoyed it because they got to learn from each other as well. So it's delivered in 12 to 14 one-hour sessions that can be delivered twice weekly for 4 weeks or 1 time a week for the remaining 6 weeks. And it can move as fast or slow as the concern significant other requires. The clinical style that's used, and this is a big distinction, it's the clinical style is motivational interviewing. It is not a confrontational approach. And my cute photo has covered up the words here. So there is no confrontation. We've actually found that a confrontation or these interventions that people do actually increase substance use for the family members and do not encourage engagement in treatment. So it's a motivational interviewing approach, helps the family member talk to their patient, talk to their loved one in an effective and loving way about their substance use. It also helps the concerned significant other become more independent and feel like they're more connected in the relationship with their substance using family member as well. And it's really good at helping these family members be able to kind of take a step back and interact with their loved one when the person is not using substances, and gets them out of the habit of nagging and protecting their loved one from the consequences of the loved one's own substance use. So the overall approach to craft emphasizes learning new skills to interact with substance using family members, heavy emphasis on the use of positive reinforcement. So when the loved one is not using substances, that's when the social interaction occurs. If the loved one is using substances, no social interaction. And then also allowing the loved one to face these natural consequences of his or her behavior, like I just mentioned. The session topics include handling dangerous situations with a substance using family member, helping the family members remember their loved one's positive attributes, especially if it's been a long history of substance use. That loved one really just becomes branded as the black sheep in the family and trouble. And so it's really important to help the family members get back in touch with their positive attributes. And these are the things that were evident before the substance use started. There are also sessions on teaching effective communication. So providing non-judgmental feedback to the loved one and how to do reflective listening for these family members. And then how to discontinue communication that's not effective at positively influencing their loved one's substance use, like nagging. Other session topics are on positive reinforcement. So how to positively reinforce abstinence in their loved one, and how to increase positive interactions. This is a big thing, and you'll see this is weaved through all of these concerned significant other or family approaches, because when substance use has been going on for a while, positive interactions with family members just dissipate tremendously. So we want to really focus on scheduling family member or scheduling activities that the family member enjoys that do not involve substances, and participating in these activities only when no substances are used that day. So this is the positive reinforcement for abstinence. And then another session topic is on practicing non-reinforcement of substance use. So ignoring or avoiding the family member when using substances or putting them on extinction, just like they did when the kids were little wee ones, for example, in the case of parents seeking craft, you know, they put their little one on a chair for a timeout. That's using extinction. And then suggesting and initiating treatment during opportune times. So the family members who are in craft, they may not suggest or suggest initiating treatment with their loved one until they've been in the treatment with craft for quite a while, several weeks. This really helps them ensure they have the good skills in place that are likely to lead to a positive outcome of their loved one engaging in treatment. And then also helping the concerned significant others develop interests and social support that's independent of the substance using family member, so that they have their own good coping in place and they are doing things that are healthy for them and involve good self-care. So the indications for craft. We see it's efficacious for alcohol and drug treatment entry. 7 of 10 individuals who've had family members go through craft enter treatment. So that's about a 70% efficacy. I'll take that efficacy rate any day. We see it's appropriate for adolescents, young adults, adults, and older adults. It's also indicated in both males and females, in transgendered or LGBTQ family members. It has been tested widely as well in a range of races and ethnicities. And so we see that it's effective with Hispanic, Anglo, African American, Black, urban, suburban, rural, and tribal families as well. It has also been widely adapted. This is the most impressive thing. If you do nothing else, to go to Bob Meyer's webpage, and you can see the manuals that have been translated into all these different languages. So it's been adapted for veterans, Aboriginal, Australians, Dutch, Finnish, German, Japanese, Korean, and Spanish. His goal, and he travels the world more than anybody I ever have met on the planet, but feels very passionate about craft. And we see there are no adverse effects or unintended consequences from using craft. So it's safe, it's efficacious, and if you can get yourself in a training, I would highly, highly recommend it. So some couples, or these are kind of couples approaches that I'll talk about next, but it can be, you know, anybody who's like living, but it's typically living with a loved one who has a substance use disorder, any person like that. We tend to focus on the folks who are in some sort of romantic relationship with the person with the substance use disorders. And so these treatments are alcohol behavioral couples therapy, or ABCT, that was developed by Barbara McCready and Beth Epstein. We also have behavioral couples therapy for alcohol and drug abuse. This was developed by Tim O'Farrell and Paul Stewart. And the focus of these treatments and their assumptions is that excessive drinking or drug use is considered a habit that can be unlearned. It's grounded in the assumption that excessive drinking and drug use is maintained in part by interactions between the user and the partner, and that this is changed most effectively by changing interactions between these partners. It also focuses on repairing the relationship between partners that have been damaged by substance use, and it's very much present and future focused. This really addresses the feature that both family members experience, both the CSO and the person with the substance use disorder, worry they're going to come into treatment and just be beat up. And we're not interested in going back and rehashing all the disappointments that have happened. We're focused on building skills right now and how to apply those in the future. And so once the patient and their family members really kind of understand that we mean it with this, they're much more happy to come to treatment at that point. And so these treatment programs consist of 2 to 3 hour initial assessments for treatment planning. So we're getting a whole substance use history, relationship history for this couple. It is delivered in 12 to 20 week sessions. So I think here you're getting a flavor of the length and the complexity of these types of treatments. Optimally, implementation occurs in an outpatient clinic setting by individuals with experience treating alcohol and drug use disorders. And it does acknowledge that intimate partner violence is frequent in substance using couples and has interventions specifically embedded in them that addresses IPV for these couples. The major elements that are included in these treatments that decrease substance use, the first one is motivational enhancement. So again, this is the general therapeutic stance, like the motivational interviewing. There is no confrontation. We treat the client with respect and as a person of value. And this is a big barrier to people entering into treatment because of the old perspectives that have been taken and old ways of thinking about people with a substance use disorder. We are not interested in making anybody feel less valuable than they are. And the goal is to increase motivation for continuing to engage in the treatment. We also do a functional analysis of the drinking. So we want to identify high-risk situations and triggers. We want to identify consequences of substance use. So what were the good and the bad things that the person got out of their substance use? And this will allow us to alter the antecedents or the activities or situations that occur before substance use in order to change the substance use and its consequences. And then we have a focus on relapse prevention. So this is helping the partners develop strategies to both avoid relapses and to cope with those that may occur so that they're limited in their scope and duration. There are also elements in these treatments to improve relationship functioning. And the first one here is improving communication between the partners. The intervention is present and future focused. So again, we do not rehash the past. We're looking at what we can do today and moving forward. And skills are taught throughout the treatment through structured interventions. So we have exercises that we're working on, and then between session exercises that we ask the partners to do outside of treatment. And this is designed to teach the couples to identify positive and negative aspects of their communication and then to practice the positive communication. The other interesting thing, and I do this in my own couples therapy too, is discussions of disagreement are only to take place in the session for the first several weeks. So we ask these couples, don't fight at home. And, you know, everybody's like, what? How is that possible? But couples are really good at limiting that and bringing disagreements to the session. And it's a huge relief to them. when they get a prescription from their provider not to fight, they're like, okay, well, we can't do this at home. And they're really actually good at it. So there's a couple of reasons for doing this. Because of the often high levels of violence in these couples, it is a safety measure to avoid that. It also allows us to help the couple get some skills in place so that conflict resolution can take place in a functional way. And that takes several weeks for that to happen. And then when they do start to be able to have discussions of disagreement outside of the session, it's limited. It's scheduled and limited. So like Thursdays at 7 o'clock for 30 minutes, we'll talk about a discussion of a disagreement that came up this week. So we're teaching them skills on how not to let this explode all over the relationship, because 80% of relapses occur because of negative interactions with a loved one. So it's a really significant trigger for relapse for folks. And then we also want to teach them how to develop positive interactions and activities. We teach the couples how to notice positive behaviors from each other and keep track of them during the week. They have a worksheet to fill out about that. And then how to increase shared positive activities. And these are a set of structured activities that the couple does throughout the treatment. We have like caring days and things like that for the couples to engage in, and they love it. Indications for these couples focused treatments, they're indicated as a standalone treatment for substance use. So they don't need to be in conjunction with individual treatment for substance use. This is a standalone treatment and can include co-occurring disorders. If we have some other psychopathology present, that this is great for that as well. The empirical evidence supports improvement in substance use, relationship satisfaction, and relapse. It's indicated in adults and older adults, so it's not appropriate for young people. It's indicated male, female, or both partners using substances. So we can have one individual, let's say it's the female in this case, who is using substances, and her husband or male partner is not. That's indicated, but both partners can also have a substance use disorder, and we can treat them at the same time. It's also been tested and found to be efficacious in American Indian, Native Alaskan, Black, African American, Hispanic, or Latino, and white couples. Also in urban and suburban settings. We haven't tested this much in our rural settings yet. And we have found no adverse effects, concerns, or unintended consequences from the use of this treatment. It's safe and efficacious. And does anyone have any questions or anything for me yet? We can answer them now. I have a hard time seeing everybody, but I will leave some time at the end as well. So at the beginning of the talk, I mentioned the pretty significant barriers that are involved in the implementation of these treatments. And I think, as you can see from my discussion of ABCT and BCT, 20 sessions is a long time, and big, multi-hour intake sessions is sometimes a barrier. So in effort to overcome some of those barriers and increase the uptake of CSO involved treatments, we developed the Brief Family Involved Treatment, or BFIT. And we have our outcome paper is under review right now from this. And what we did in this treatment is we distilled the core activities of alcohol behavioral couples therapy for integration into ongoing alcohol treatment. Part of the reason we have a focus on alcohol here is just pragmatic. It was funded by the National Institute on Alcohol Abuse and Alcoholism. So we had to have a focus on alcohol treatment here. But this treatment is designed to be just dropped into any other substance use treatment. So a person can be in any individually focused substance use treatment, and then you can just drop in 3 sessions of BFIT with that. And we just got our notice of award last week for our big clinical trial of BFIT. So we will be testing this in a telehealth format with veterans around the country who were involved in the STAR program. So we'll be recruiting primarily out of the Charleston VA, but possibly also out of the San Francisco VA, and they have a pretty wide reach. So we're hoping to also engage patients who are in rural settings for the test of this. But for BFIT, this is a 3-session treatment. So we've, as I mentioned, distilled down these core elements, and we are focusing on enhancing family support for change efforts in the patient. So we want the patient to really feel supported in their efforts to change their drinking or substance use. And we want to teach strategies to enhance positive reciprocity between the patient and the family member. So increase positive activities, much like those that we see in the longer treatments, how to do these, weekly, how to have positive activities and planned activities with their loved ones. And then we also focus on teaching constructive communication skills to the patient and their family member. So with this one, it doesn't necessarily have to be a romantic partner either. This can be any concerned loved one. Tends to be a family member. It can be an aunt, uncle, cousin, sibling, a fictive family member, anyone like that who has a close, meaningful relationship with the patient. And so the strengths of this, these came from our pilot clinical trial that we did for BFIT. The clinicians reported that it was easy to learn for them. So it's 3 sessions. And I did the training and all of the treatment fidelity monitoring for these clinicians, and they did great with it. As I mentioned, it's designed to be dropped into any ongoing substance use treatment. And our preliminary outcomes suggest pretty large effect sizes for the efficacy in days abstinent and reductions in the proportion of days of heavy drinking as well. So we tested this in an inpatient treatment facility in Albuquerque, New Mexico. So we had other comorbid drug use disorders, methamphetamine, opioids, and things like that. And so in the days abstinent, we had an effect on those other substances as well, not just alcohol. And then in follow-ups with both the patients and the concerned significant other or family member, they loved it. And that they felt that the sessions really opened up possibilities for them to continue to improve their relationship going forward and being able to remain abstinent and have support for that if the person was struggling with craving that day. For instance, they had a positive way to be able to talk about those things that didn't cause alarm in the family member when it was brought up. And so I think, with a lot of family, I've been doing family and couples-based treatment for like 2 decades now. And you never are going to fix everything for a couple, but the goal of the treatment is to give them some solid skills and then put them on a positive trajectory. And I think BFIT is one way to do that, and we're really excited to be able to test it in a larger clinical trial. That's almost a hybrid dissemination trial, because we'll be using real clinicians in the VA settings. So one of the last approaches I'm going to talk about today is for children and adolescents. It's called Brief Strategic Family Therapy, or BSFT. It is a short-term family-based intervention that targets children and adolescents. This approach considers the symptomatology and substance use to be rooted in maladaptive family interactions. It's 12 to 16 family sessions, so I know that doesn't sound very brief, but it can be done in as few as 8 sessions and as many as 24. Excuse me. There's also a significant focus on treatment engagement in this approach, much like in CRAFT. It's based on 3 principles. The first is a family systems approach, where it's discussed and explained to family members that they're interdependent. So what affects one family member automatically affects another family member, and that families are the strongest and most enduring force in development of children and adolescents, really throughout their life. And that patterns of interaction in the family influence behavior of each family member. So sequential behaviors among family members that become habitual and repeat over time. And so this treatment is looking at interrupting some of those habitual and maladaptive patterns and helping the families learn new patterns of interaction in some nice, real practical ways for these families. So we also understand that families play a large role in adolescent behavior problems. Parental substance use or antisocial behavior on the parent's part influences either parent under or over involvement with the adolescent. So if the parents are kind of laissez-faire, hands off, kids tend to find negative social groups to interact with. Or if the parents are over involved, we see this leads to a lot of anxiety in children as well. And then poor quality parent-child communication plays a large role in adolescent behavior problems. A lack of clear rule and consequences for adolescent behavior. Inadequate monitoring of adolescents' activities with peers. So good quality parental monitoring, parents know who their kids are with, they know those kids, they know the parents of those kids, they know what the kids are doing, and they follow up with them. That's good, healthy quality parental monitoring, so they work to teach that. And then poor adolescent bonding to the family and poor family cohesiveness in general. These all contribute to adolescent behavior problems and are targets for intervention in BSFT. So the treatment strategies of BSFT, they really have a focus on practicality. They want folks to be able to use these behavioral strategies, and they want them to work quickly and effectively. So for example, they'll do behavioral contracting that addresses poor communication and lack of limits and consequences. So they'll put it out on a chart or a piece of paper so that everybody knows what the rules are and what are consequences for for having poor behavior, for example, as well as what are the consequences for having good behavior? What are the good things that happen with that? All the rules are laid out for the entire family to see. It's also problem focused. So we're focusing on limiting the scope of treatment to those factors that directly affect the adolescent substance use. So, for example, the absence of clear family rules for appropriate and inappropriate adolescent behavior versus marital or financial problems. So we're going to focus on these clear family rules, not these more global stressors that may be going on in the family. And it has a really nice generalizable effect too. Once we start to set these clear family rules for these families, we see it kind of generalized to other areas of the family functioning and even the marital relationship in helpful ways. So the treatment strategies are also planned. So the clinician works with the family members to determine what problematic interactions in the family are contributing to the problem, and they make a clear and well-organized plan to correct them. And it's out there on paper in black and white for the entire family unit to see. The strengths of this treatment is it really targets self-sustaining changes in the family environment, because the family is the context in which these kids live. The number of sessions needed depends on the severity of a problem. So this is nice in the way it can be tailored to the needs of different families. It has also been extensively evaluated. We have over 25 years of scientific support for the efficacy of this treatment, and it's manualized with training programs for clinicians across the country. It's also a flexible approach that's adaptable to a broad range of family situations and service settings and variety of treatment modalities. So, for example, it's can be used in clinics, substance use treatment centers, so, specialized treatment centers, just family outpatient settings, day treatment, etc. It's highly tailorable. And so I've just got some lists of resources about these treatments now. These are some resources, and these slides are available to everyone. They'll be uploaded for the group, so these resources you'll be able to access them. But Bob Myers and Brenda Wolf have written a great book, and so did Jane Smith and Bob Myers. Getting Your Loved One Sober, Alternatives to Nagging, Pleading, and Threatening, and then Motivating Substance Abusers to Enter Treatment, Working with Family Members. If I recommend Getting Your Loved One Sober to almost everyone I see. It's really helpful, and it's a great kind of self-help book. And then Bob Myers' website is here. He has a myriad of resources, as well as when he's got trainings coming up in both community reinforcement, approach to substance use, and craft. And then also I refer almost everyone to Smart Recovery and the family resources. These family resources on Smart Recovery really mirror these craft resources, and it's great mutual help setting as well. For ABCT, they have a really nice treatment manual called Overcoming Alcohol Problems, a couples focus program. It's published by Oxford University Press. I have the link to where you can purchase it there. If you purchase the manual with them, the nice thing is all the worksheets are accessible to you, so you can download them, or if you're doing telehealth, you can email them to your patients and things like that. So they've got it right there, makes it super usable. And then Barbara, she is now Professor Emeritus at the University of New Mexico. But she has some links on her website, and you can get additional resources there at the Center on Alcohol and Substance Use at UNM as well. And then for BSFT, same set of resources at the bsft.org website, trainings, manuals, clinical resources, and things like that. And hopefully we'll have some outcomes for BFIT here shortly as well. And so I would be happy to take any questions now or comments or anything like that. I think we have plenty of time for them today. I can stop sharing. And so you can just unmute yourself and pipe up or type it in the chat, whatever you feel comfortable with. I'm happy to answer any questions.
So, Dr. Fink, what do you do if you have family members that are just kind of burned out? They've been through this a jillion different times and they're fed up and, they're just not willing to engage. You got any ideas for that?
Yes. Each of these treatments specifically addresses that in the early sessions, because I mean, that's the truth. And a lot of family members, I knew family members suffered. It wasn't until we actually did some focus groups with family members. That was one of the citations that I cited when we were developing BFIT. We wanted family members to take a look at our materials and give us feedback on them. And these poor folks, I mean, I think they suffer more than folks with the substance use disorder for it. But they all want to help in a constructive way. And so when they learn that, oh, we're going to be given actually constructive tools to do something, and it's totally different from everything else I've been trying that has contributed to my burnout, they're pretty happy to engage at that point. But it's the first sessions of all of these treatments for sure, because that's such a real thing with them. And let's see, got a couple things in the chat. Thank you, Dr. Hilton. And yes, all of these slides and the resources are posted to the CD seminar website. So you'll be able to get the links to them. Any other questions or comments? I have one for the group. How many of you do family-focused treatments for substance use? Yeah, Dr. Brand, I knew he did. He's an old master at this. Well, if nothing else, so I take it nobody else does. Hopefully I've stimulated some interest in, oh good, we've had one person, a couple of people sometimes do it. I hope if I've done nothing, I've stimulated some interest in maybe giving these a try. My email was on the front slide, so please, if you're would like to do this, and or have gotten a manual and you have questions, or have done a training, or just have questions about working with families, please feel free to email me. I'd love to be able to consult and help you through this. It is so incredibly beneficial to the people that we treat and the people that love them. So,
Hey, Dr. Fink, I have one question for you. Thank you so much. This is a really informative, great presentation. I had a question out at McLean. That I believe that they had a craft-based family support group.
yep.
And I don't know if it's any sort of a national thing or if those are available online or if that was just something that a group of clinicians kind of got together and created at McLean, or if that's something that, do you know anything about that sort of a group-based family support group that's based on craft? Or
There might be through the Smart Recovery webpage in their family resources. I think they have some there. We are also going to be beginning to offer that here. I'll be leading that group Wednesdays at 4 o'clock. We are starting sometime in October, so we can advertise that to the group too. If any of you have family members who would be interested in participating, but there's education about substance use and then how to effectively navigate this with your loved ones as well. But I love it. I love working with families. It can be a little intense at sometimes, but the benefits for folks is just outstanding.
great, that'll be awesome. I'll be sending people that way. So that
Okay.
sounds like a really good benefit for us. So
Thanks. Any other comments or questions from the group? I hope no one fell asleep. So everybody's quiet.